slides. There we go. I want to mention up front that this presentation does not include data on safety related to M vaccine, either pre or post licensure. Those data will be discussed next by Dr. Su. Next slide, please. Measles, mumps, rubella, and varicella caused significant health burden pre-vaccine in the United States. Highlighted on this slide are several severe consequences of these diseases. During the last major rubella epidemic in the US in 1964 to 65, in 1 year, 11,000 pregnant women lost their babies, 2,100 newborns died, and 20,000 were born with congenital rubella syndrome that causes deafness, heart defects, and developmental delay. Before the introduction of the measles vaccine, each year an estimated 48,000 hospitalizations and 400 to 500 deaths were due to measles. Pre-vaccine, mumps was the leading cause of viral encephalitis and sudden onset deafness. And for varicella, each year in the early 1990s, 10,500 to 13,500 hospitalizations and 100 to 150 deaths were varicella related. Next slide, please. The introduction of vaccines to protect against these diseases in the form of monovalent and combination measles, mumps, rubella, MMR, or measles, mumps, rubella, varicella, or MMRV, coupled with attaining and maintaining high coverage rates for more than 90%, led to dramatic reductions in disease burden in the US. Elimination of endemic measles in 2000, elimination of endemic rubella in 2004, a 99% decline in mumps cases by early 2000, and a 97% decline in varicella incidence by 2019. Next slide. Two options are available in the US for measles, mumps, rubella, and varicella vaccination. Combination MMRV vaccine or MMR vaccine plus varicella vaccine. Vaccination is recommended as 2 doses with the routine ages being 12 to 15 months for the first dose and 4 to 6 years for the second. The MMRV vaccine available in the US, ProQuad, manufactured by Merck, was licensed by FDA in September 2005 based on non-inferior immunogenicity of the antigenic components compared with simultaneous administration of MMR vaccine and varicella vaccine. The efficacy of the measles, mumps, rubella, and varicella components of MMRV vaccine was previously established in clinical studies with the monovalent vaccines. At the time of MMRV licensure, the burden of disease for these diseases was too low to perform efficacy clinical trials in the US. Of note, immunobridging trials are an established approach for the development of vaccines. Next slide. Immunogenicity after the first dose of MMRV vaccine versus MMR plus varicella vaccines in children aged 12 to 23 months was assessed in 4 randomized clinical trials. 5,446 people received MMRV vaccine and 2,038 received MMR plus varicella vaccines at separate injection sites. In these studies, the endpoints assessed, seroconversion rates, and geometric mean titers were similar between the 2 groups and met the pre-established criteria for non-inferiority. Immunogenicity after the second dose of MMRV vaccine versus MMR vaccine with and without the varicella vaccine in children aged 4 to 6 years was assessed in 1 randomized clinical trial. 399 people received MMRV, 205 received MMR plus placebo, and 195 received MMR plus varicella vaccine. Findings also met pre-established criteria for non-inferiority. As you heard during the last meeting, an ACIP working group assessed the evidence for safety after MMRV compared with MMR plus V in 2008 and 2009. Their assessment on vaccine performance was that given the non-inferior immunogenicity, effectiveness was assumed to be equal. Next slide, please. This slide illustrates the timeline of recommendations for MMRV vaccine use in the US. Upon licensure in September 2005 for use in children aged 12 months through 12 years, MMRV vaccine was preferred over separate administration of MMR and varicella vaccines, consistent with ACIP recommendations at the time on preferred use of combination vaccines. In February 2008, a preliminary vaccine safety finding from 2 post-licensure studies that found an increased risk of febrile seizures after the first dose of MMRV vaccine led to ACIP removing the preference for MMRV vaccine use versus MMR and varicella vaccines for both dose 1 and dose 2. After further examining the safety and other evidence, including use of MMRV vaccine has the benefit of requiring one less injection than the alternative of MMR plus varicella vaccines, epidemiology of febrile seizures, parent and provider input, and consultation with ethics experts, in June 2009, ACIP issued updated recommendations. Next slide. These updated recommendations are the current recommendations and state that for the first dose of measles, mumps, rubella, and varicella vaccination at age 12 to 47 months, either MMR vaccine and varicella vaccine or MMRV vaccine may be used. Providers who are considering administering the MMRV vaccine should discuss the benefits and risks of both vaccination options with the parents or caregivers. At the time of the publication of the recommendations, CDC provided implementation guidance that, unless the parent or caregiver expresses a preference for the MMRV vaccine, CDC recommends that MMR vaccine and varicella vaccine be administered for the first dose in this age group. For the first dose at age greater than 48 months, and for the second dose at any age through 12 years, that is 15 months through 12 years, MMRV is generally preferred over separate injections of MMR vaccine and varicella vaccine. Next slide. No post-licensure vaccine effectiveness estimates are available for the MMRV vaccine used in the U.S. With measles and rubella being eliminated in the U.S., mumps and varicella at very low levels, there are not enough cases of disease or outbreaks in children to assess vaccine effectiveness in the U.S. Those vaccinated with MMRV or MMR and varicella vaccines continue to have very low rates of disease for measles, mumps, rubella, and varicella in the U.S. There have been no reports to CDC indicating concern for lower MMRV vaccine effectiveness compared to use of the separate component vaccines, consistent with the immunogenicity results seen in the clinical trials. Next slide. As far as utilization, MMRV vaccine accounts for 15% of first dose measles, mumps, rubella, and varicella vaccination among children aged 19 to 35 months. In most states, MMRV vaccine is used for about 10% to under 20% of first dose based on the first and third quartiles. In children aged 4 to 6 years, MMRV vaccine accounts for 75% of second dose vaccination. Next slide. To conclude, MMRV vaccine is one of the two options for vaccination of U.S. children for protection against measles, mumps, rubella, and varicella. As the ACIP assessed in 2008 and 2009, given the balance of risks and benefits of a first dose of MMRV vaccine compared with the first dose of MMR vaccine and varicella vaccine, and the importance of individual values and preferences in weighing these risks and benefits, maximizing choice is an important ethical principle, and decisions should be made by providers and parents or caregivers on a case-by-case basis. The two vaccination options, MMRV vaccine or separate injections of MMR vaccine and varicella vaccine, are considered equivalent in terms of protection against disease. Due to the current recommendations, most MMRV vaccine in the U.S. is among children aged 4 to 6 years for the second dose of MMR and varicella vaccination. Vaccination for measles, mumps, rubella, and varicella has led to at least a 97% reduction in all 4 diseases compared with the pre-vaccine era. Thank you.
Thank you so much for that presentation. From the members, do we have any questions or comments?